We knew that SLT laser could lower pressure. What we didn't know is whether we should use it. So what we did was we took newly diagnosed, freshly presenting patients, new to the hospital, never had drops before, never had treatment before, and randomized those to either medication or to SLT laser. And what we found was that over 3/4 of the patients were at their target pressure that we'd preset before we treated them, based on severity and how high the pressure was at the start. We also extended the study to 6 years, so we had a 3-year extension. And we then found that even after 6 years of laser treatment, 70% of the eyes were meeting their target pressure. Now, they were allowed 1 or 2, and in some cases 3 lasers, but the majority of those had only needed 1. There was another really powerful outcome from the trial, and that was looking at the visual fields. What we were able to show was that if you'd had laser first, or if you'd had drops first, you had a different protection of your visual fields. Now that's really powerful because we didn't know that that was going to be different. The SLT first group had more visual field protection. And it's visual fields that patients care about, it's visual fields that as clinicians we care about. It means visual function. How well does the eye work? How well does the patient see? The patients on average saw better at the end of 6 years if they'd had laser first than if they'd had drops first. And that's pretty powerful. So selective laser trabeculeplasty, SLT, at the beginning of that patient journey, when they're first diagnosed, was able to keep 70% of eyes free from medication, free from the need for eye drops, free from exposure to preservatives, free from the complications and drop allergy and all the difficulties you have with medication. We looked at the need for glaucoma surgeries, and we found that the need for trabeculectomy was much higher, double that of the laser group in the medication group. So the medication arm ended up needing more surgery. So if you started off with eye drops, 6 years later you'd had a lot more chance of surgery than if you'd had laser first right at the beginning. I think one of the great advances for SLT is that it causes such little tissue damage that it has got a huge safety margin. We're not cooking the TM, we're not causing coagulation of the trabecular meshwork beams. Partly that, I think, is down to the precision of the energy delivery, the knowledge of getting exactly the kind of tissue response you want to get from the end organ tissue, the trabecular meshwork, really where the drainage itself is happening. When we're communicating with patients what we would like to offer them, I normally say, look, we need to treat your pressure, and we have 3 ways of doing that: laser, drops, and surgery. Surgery's for the advanced disease, probably not for you, hopefully never. So we have to choose between laser and drops. We've got the benefit of this randomized controlled trial that shows that patients do well without needing drugs, without needing medications or eye drops, if they have laser first. In fact, the results of that trial were powerful enough that we've got the European Glaucoma Society treatment guidelines, we've got the National Institute of Clinical Excellence in the UK, which determines what we should be offering patients, and the American Preferred Practice Patterns, all suggesting that we should be offering every newly diagnosed patient with open-angle glaucoma and ocular hypertension SLT laser as their first treatment. A lot of the interventional glaucoma paradigm shift is discussed around use of minimally invasive glaucoma surgery in MIGS at an earlier stage than you might have done otherwise. SLT laser as primary therapy is almost the perfect example of that shift. I'm still surprised that so many people are not offering SLT as first-line treatment. Certainly that's what I would want. I think some of that's inertia. I think some of that's access to having a laser themselves. They don't want to lose their patients to other clinicians if they have to send them up the road for a laser. So what I say to a lot of clinicians who are hesitant about offering laser as first line is, I think you're underestimating the problems that medications cause. With all the attendant risks, side effects, preservative exposure, all the knock-on effects of preservative exposure, you can prevent all of that by doing laser early on.